Welcome to the Dr. Mary Louder podcast show, where we explore the messy, magical, and deeply human journey of healing. I'm your host, Dr. Mary Louder, a board-certified osteopathic physician, an accidental shaman, and a lifelong student of human experience. Together, we're going to talk medicine, wellness, and culture in a way that's grounded, perhaps maybe a bit cheeky, but always from the heart. And don't miss Gadgets, Gimmicks, and Gotchas, my reoccurring segment where we lovingly call out the fluff and highlight the stuff that actually works. So grab your favorite brew, coffee, matcha, or that mysteriously green smoothie and settle in. It's time to get this party started with a strong dose of soul medicine. Welcome to the Dr. Mary Louder podcast show. I'm so glad that you're here. We have a special guest today, Dr. Julius Torelli. And Dr. Torelli is a cardiologist and he's kind of long in the tooth regarding his cardiology career and 4 decades of practicing medicine. And he's learned that many symptoms and illnesses have no physical findings. And that's kind of curious as a cardiologist, let me tell you that. And he's calling these medically unexplained symptoms. Entities such as headaches and irritable bowel come to mind when I think of these. And over the years in medicine, I've noticed kind of a similar thing where patients have very real and debilitating symptoms, and often physically we don't find something. The labs are normal, everything's normal, the exam was normal, there's nothing wrong. But there is, isn't there? I think there is. So does Dr. Torelli. So he's going to let us in on what he is calling medically unexplained symptoms. And I'm really interested in how his thinking has evolved over time regarding this. And we're going to be in conversation and exploring how he defines that category, what he thinks might be missing in our conventional care, and how he's come to understand the role of the nervous system and emotional health in those areas. So welcome to our conversation, and welcome Dr. Julius Torelli. Welcome, everybody, to the Dr. Mary Louder podcast show. We got a special guest, Dr. Julius Torelli, and he's with us from the East Coast, from North Carolina and Virginia. We're going to throw in both states. We're going to try and get as many of the 50 states as we can today. And he's a seasoned cardiologist, and we're going to talk about the healthcare system in a way that, it could be a paradox because it's 2 docs for sure, but also because we have a lot of experience when you put both of us in this room together. And so it's going to be a really fun conversation. So welcome, Julius. Welcome to the podcast. We're glad that you could take some time today.
Thanks, Mary. I appreciate it. I appreciate the opportunity and the honor to be here.
Yeah. So tell us a little bit about your journey as a physician. First of all, why did you want to be a doctor? How did you get there? What's some of the highlights?
Um, those are great questions. So, but believe it or not, I think it was something I always thought about. But when I was in a teenager, late teen, before college, I ran across this book at a department store on the placebo effect,
Hmm.
and I absolutely became fascinated with this concept of the placebo effect, which I didn't understand. I tried to read about it. I tried to go to the library and find stuff, but back 40 plus 50, whatever years ago, that was not as easy to do as it is today. I
Mhm.
really couldn't find very much. And then, but intrigued me enough that when I went to college, I went to pre-med. I wanted to go to medical school, and I minored in psychology, and I
Mhm.
thought I would learn about the placebo effect then, but I didn't learn anything about it then
Yep.
either. But uh, not until medical school, when the placebo effect was then presented as a nuisance, as this pesky thing by the pharmacologists or in
Yep.
our pharmacology class, because they were like, because of this nuisance, pesky effect, this phenomenon called the placebo effect, we have to do these very expensive, double-blind, placebo-controlled, randomized trials to show that our billion-dollar drug works better than a sugar pill.
Mhm.
And I always thought, like, this was fascinating to me because here he was saying, this was a nuisance,
Yeah.
and it works whatever, let's say 15 to 30% of the time, and I was sitting there going, "Man, shouldn't we try to, like, amplify that? Maybe we can get it to work 50 to 75% of the time."
Right.
And I remember talking to my classmates about it, and they were just kinda like they were I mean, there was no interest, and so I
Right.
guess I was always the oddball sort of in that way, but
Mhm.
that's one of the things that spurred me into medicine, and just this that and then, human behavior and what I'd like to think of as the non-physical dimensions of health,
Right.
as well, because we concentrate so much on the physical, but those are the things that really fascinated me,
Yeah.
brought me into medicine.
Well, that's interesting because a lot of medicines, in order to get approved, have to be as good as placebo.
Right.
And someone's kinda like, "Well, can't we just go to placebo and not have the side effects?" Right? So, it's kind of a fascinating concept. What, specialty did you choose then?
So I did internal medicine, and then I was trying to decide. I actually had a mentor, who was a psychiatrist, and never thought about psychiatry, but I had this fascination with the placebo effect with mindset and how mindset affects medicine with human behavior, and I really considered psychiatry, but the problem I had with psychiatry was that, a lot of it was just dealing with psychotics and schizophrenics and just medications. I found that psychiatrists had 15-minute appointments, which I totally could not understand. I said, "How could you get to know this person in 15 minutes?" It was really just about medications, and so I was fascinated with cardiology, and cardiology came easy to me, so I went into cardiology. I was at the Cleveland Clinic, and so it was a great program, and I enjoyed that. But even as my practice developed and as I looked at the practice of medicine in general, no matter what specialty, I found that if you look at all the people who come to see doctors with a new complaint, not the ones that are well visits, obviously not the one with chronic sort of issues, but patients with new complaints, new illnesses, new um, ailments, what have you.
Yeah.
I found, and it didn't matter the specialty. I found that the great majority of those people, we never found a reason, a physical reason for their symptoms. So I think headaches, and belly pain are probably the two poster childs for this, right?
Mhm.
Uh, but it didn't matter. It could be headaches, neck aches, back aches, muscle aches, fatigue, chest pain, belly pain. Most of the time, each specialty had its own name for these things, right? So the neurologists call them migraine headaches or tension headaches, and the cardiologists call it non-cardiac chest pain. The gastroenterologists call it irritable bowel syndrome. The primary care and maybe neurologist and or call it fibromyalgia, or chronic fatigue syndrome. So these were fascinating to me, these medically unexplained sort of symptoms, because it's clear that, I mean, these can be disabling, right? Certainly debilitating. And yet, we never found a cause, a physical cause. And then we just use medicines to try to treat these because truth is in the at least on the allopathic side of the healthcare system, we really only have 2 tools in our toolbox. We have procedures and surgeries and stuff, and we have pharmaceuticals. Outside of that, we don't really have a lot. So if they don't need surgery, they don't have a brain tumor causing their headache, then we, resort to medications.
Mhm.
And that's fine. I don't even really have a problem with the medications. However, it's not treating what everyone would agree is the root cause
Mhm.
of the belly pain or the headache or the chest pain or whatever. And so I really started heading into this field that I call behavior cardiology, and kind of went into more of the preventative wellness side of that.
Yeah, that's really interesting because so behavior cardiology, we would consider you a non-interventionalist, right? An interventionalist would be stents, valves, changing the anatomy. And there's a lot that can happen before those changes are needed, right? But it's interesting because at the same time, um, heart disease is one of the things that can take us out the quickest. I mean, 30% of the people that present with their first symptom of cardiovascular disease is sudden cardiac death. So you're kind of sitting in a bit of a paradox there, aren't you? Of the symptoms not having physical signs to them, right? And then, which would make it more in the psychological, emotional, mental health world. And yet, if you miss it and miss the big one, the person could have the big one, and there you go. How did you reconcile that paradox?
Not easily. And so, that it is a little bit difficult because, mostly from a medical legal kind of standpoint,
Mhm.
but because people can present, with chest pain as an example, and, for coronary disease to cause chest pain, the blockage has to be significant. Significant is over 70 or 80% blockage, right?
Mhm.
So people can actually have blockages of less than 70%
Yes.
and not have any symptoms. But if they so let's just say someone had a 30% blockage, they come in with chest pain. You can do a fancy, like, nuclear stress test or a cardiac PET scan or even a cardiac catheterization and show, you know, they don't have ischemia, so that blockage is not causing a lack of blood flow to that area,
Mhm.
right? However, even though that is all true, it may not be causing their chest pain at that time, but tomorrow, that plaque could rupture, that 30% or 50% plaque could rupture and then cause a heart attack, and so it looks like you missed something,
Mhm.
but you didn't really miss anything. What you said, well, there wasn't a significant 70 or 80% blockage yesterday, but today, that 30% blockage ruptured and a blood clot formed on top of it, blocked off that artery acutely and caused the heart attack. So again, from the it becomes a real challenge, especially if you're seeing a lot of patients because, that rupture is an unpredictable event.
Yeah.
Um, and so it is difficult.
Yeah, it's interesting because going through residency, I saw cardiology as one of the more precise specialties. It's fluid dynamics. I mean, I mean that, with all respect, I thought, well, okay, it's calculations, it's figuring this out. But when you get in and figure out who needs a stent, who doesn't need a stent, there is no predictability about that at all, is there?
Yeah, I mean, that's one of the reasons I went into it was because it seems so I was very one of these very logical kind of minded, people, and it was, as you said, predictable, and it came easy to me, right?
Yeah.
The physiology of the heart,
Yeah.
I could understand it like you just sort of suggested, but when in the actual practice of cardiology, there's a lot of complexities to it.
Mm,
Unfortunately, again, because you're dealing with this unpredictable, potentially life-threatening process, there can be a lot of ramifications, and so you have to keep all of that in mind.
yeah.
Uh, but cardiologists from a legal standpoint have gotten in trouble when they really didn't do anything wrong.
Yeah.
It was just sort of bad timing, unfortunately.
Yeah, I see that as certainly as I get older, and certainly as my family and even myself have grappled with, cardiovascular disease and coronary artery disease, and my mom passed from a dissecting aortic aneurysm, and so there was nothing predicted about that, quite fascinatingly, and of course, it just happened, and that was the big one, right? So, um but it's interesting too, because the heart before we get into some of the stuff you're doing now, the heart is a vortex, right? We see it as 4 chambers, up, left atria down to the left ventricle, out to the aorta, back through the, right, atria to the right ventricle, back to the left atria. So but if you unwind the heart as a muscle, it's a spiral.
Yep.
Can you talk about that a little bit? Because I don't think people really realize that.
Well, the embryology of the heart is one of the embryology is so complex when you look at it. At one point, we look just you can't differentiate a human from a chick embryo, right?
Yeah.
Uh, and yet, when you look at the heart forms from a tube that folds over on itself and then folds again, and it forms, basically an S, and then the walls in between that S fenestrate, they fall apart, and that forms the sac, that forms in the left ventricle. the left atrium actually forms from the lungs. It's the pulmonary vein confluence comes together, forms left atrium. That then attaches to the left ventricle above the mitral valve. So it's a fascinating sort of thing. And as much as we understand about the left ventricle, which is the main pumping chamber, and how it works, the contraction, we always looked at it historically when we say heart failure. Well, if the heart is weak, it's failing. And today we understand, yes, maybe two-thirds of heart failure is due to a weak heart. But we also understand this other concept now of diastolic dysfunction, or what they call heart failure with a preserved ejection fraction. So the ejection fraction, the pump can be normal or near normal, and yet people can have heart failure symptoms all the time. So the heart has to pump, but it also has to fill. Right. And so as it relaxes, it actually kind of sucks blood in. And then when it contracts, it sort of contracts in a spiral kind of fashion. So there's a more complexity to
It
it
is.
than just a simple, this thing squeezes or it doesn't squeeze. There's a lot more to that. We see people all the time who, have terrible hearts, like severely dysfunctional pumps, yet have no heart failure symptoms. And we have people who have normal or near normal hearts, very stiff hearts, who have heart failure symptoms all the time, but have a normal squeeze. So there is that for sure.
Yeah. I would say that's different than when I went through my cardiology training, well, let's call it a few years back, right? In the 90s. But that was, I don't know that I think we were just kind of understanding diastolic dysfunction at that point. Um,
We talked about it. I finished my training in 92. So I was
yeah.
in my cardiology training from 89 to 92. And diastolic dysfunction was a term,
Yeah.
again, very poorly understood. We certainly didn't have the term heart failure with a preserved ejection fraction.
No, we did not.
Much more common, much more
Yeah.
novel or newer term.
Fascinating. And I think that that's really important because when you look at the heart from a kind of a sense of wonderment or awe, the fact that it went through all of that for embryological development to give us this thing that continually works is just amazing.
It is. I still, yeah, look at that. I look at it, because, I look at an echocardiogram or whatever. I've seen thousands of echocardiograms, and I look at that pump and I'm like, doesn't it ever get tired?
I know, I wondered
Why?
that.
Because, if you're lifting weights and stuff, your arm gets tired, or,
Yeah.
and well, how is it that this muscle never gets tired? And it really doesn't get tired, believe it or not. And they've even done studies, where taking the heart out, and if you give it the right milieu, right, the right um, uh, s-
Like
chemical
environment, yeah, yeah.
and stuff, and put the right environment in there, it will continue to beat, for a long, long time. And so it is sort of a
But
belief.
it's a fascinating organ, it really is. And then, also if we as we get to the emotional part here, because that's where we're going, the heart's not just a pump, it's an emotional component to our beingness.
Mm,
There's more nerve endings that go from the heart towards the brain than from the brain to the heart.
yeah, yeah.
And I've understood the reason that that's important, and please correct me where I'm wrong here, is because we're sending more information up to be perceived than we are just telling the heart what to do.
Yeah, that's again something that I think is it's even today is poorly understood. Certainly in 30 plus years ago when I was in training, we knew, that the vagus nerve innervated, came from the brain, that the 10th cranial nerve innervated the heart, but we knew very little about it really.
Mhm,
And I think we still know very little about it, honestly,
mhm.
but at least we acknowledge it more, right? That there is this bidirectional communication
Yep.
between the brain and the heart. And, all of these, it's interesting now because there's so much research on, vagal nerve stimulators,
Yes.
these devices that you can implant.
Yes.
It's the literature kind of shows, there's benefit in many different areas, depression, sometimes epilepsy, heart failure, stroke rehab, even autoimmune diseases like rheumatoid arthritis and multiple sclerosis. but these are devices that you plant to stimulate the vagus nerve, which when you stimulate the vagus nerve, you're stimulating the parasympathetic arm of the autonomic nervous system, right? So the autonomic nervous system has these two arms, the sympathetic, which is the fight or flight arm, and then the calming side, which is the parasympathetic, which is really, mostly the vagus nerve related. And, and again, just coming to realize that there are these techniques besides devices that you can do, like humming as an example, meditation, mindfulness that, stimulates the vagus nerve, that stimulates the parasympathetic nervous system, that then calms the whole system down.
Yeah, that's just amazing. So if we're going so let's go to Vegas because, everything that happens in Vegas, in this case, does not stay in Vegas. It goes everywhere in the body, right? So let's go there because the interesting thing about what you're doing now is that when you're looking at these folks who maybe have symptoms, but you're saying you're not finding things physically wrong with them. Now, in my world, I get that those folks back to my office saying, or coming to me saying, I've been around the block and people are all saying this is in my head. And that's a short bypass answer of saying they couldn't find anything, labs are normal, I still feel horrible. You're coming from a world where if you miss the big one, it's got, significant weight behind it. In the primary care world, honestly, that's the majority of our patients where, have they gone out to specialists? Things have been confirmed of not existing or existing, so ruled in or ruled out. Coming back saying, "Now we need an explanation, doc. I still feel horrible." And sometimes I struggle to find physical reasons why. I use functional testing, I use a lot of nutritional testing, I get into emotions, and I think the emotions is where I've unlocked the majority of changes for folks in bringing that, more to the surface and to the forefront, and I think that's where, you found your pocket of gold as well. So talk about that and how you transitioned into that from being said cardiologist.
Well, it actually started in medical school, and I don't believe in coincidence. Somehow everything happens for a reason. We just don't understand it maybe at the time.
Right.
And it happens at the right time. And it was the last week of medical school, and I was doing a family practice rotation. I was in the office working with this older family practice, mentor, and this woman came in, middle-aged woman, with terrible, nausea, vomiting, and dry heaving. She had been sick for about 3 days, couldn't keep anything down. She was very dehydrated. And so he was like, "What do you wanna do?" And I was like, I don't really know what's going on." I said, "But she's dehydrated." And back in those days, this was 80 what, 86? So we could 40 years ago. You could put people in the hospital for things to right? Tests, but he
Right.
goes, so we admitted her, we hydrated her, which was the most important thing, and we ran several tests, and over 3 days, everything came back normal. And so I went to discharge her, and she was feeling a bit better, and I was sitting down writing her discharge diagnosis in her room, and I was making small talk, and I said something corny like, "Well, we'll get you home where you can get some real rest because you can't rest in the hospital." And she said, "Oh, I wish." And I was like, "You wish? What do you mean you wish?" She said, "I wish I could go home and get some rest." And I was like, "Why can't you?" She says, "Well, in the last 6 weeks, my husband left me, my dog died, and my house burned down."
Oh,
So I was sitting, fortunately,
yeah. Holy
in
cow.
that instant, my thoughts started racing, right? So the first thought I had was, well, that's why she was sick. That was the very first thought I had. That just seemed intuitively obvious to me. The
Yeah.
second thought was, well, wait a minute. It, I haven't learned anything. I'm in the last, this point, it's 2 days before I'm graduating. Like, I haven't learned anything about this in my education. That was the second thought. Then the third thought was, well, if I haven't learned anything about it in my education, it must not be a thing.
Oh, that was an interesting conclusion.
It wasn't one. And then the fourth thought was, well, I've got a whole medical school library. access to a whole medical school library. I'll go in and read about this. And I was like, I don't know where to even go and read about this. And so I was stunned. I told, the teacher, my attending physician, when I got to the office about it, and he was sort of like, it was probably a virus, probably viral gastroenteritis.
Yeah.
Which so I think the first thing I learned in that day was, if you don't know what's going on, just call it a virus.
That's right.
And then I remember, telling some of my classmates about it. They didn't buy into it. It was a very busy time. I was in Tampa, Florida. I was moving to Cleveland. It was, a busy time. So, but that patient stayed with me.
Yeah.
Then I saw this, in your training, most of the training is in the hospital, right? Not so much in the office, but even in the hospital, I saw this kind of pattern recurring, which was these significant symptoms, when and medically unexplained. Again, you don't, her tests were all normal, and you sort of find this, and and then again, as I went into practice, as I was saying, I found that
Yeah.
it didn't matter the specialty, whether it's primary care or neurology or rheumatology or cardiology or gastroenterology. That same pattern we saw over and over again. And so they they didn't teach me this in medical school, but body workers, massage therapists and rolfers and such, you know, as I got to know some of them, they were familiar with this concept that emotions somehow get stored in the body.
Yeah.
And they couldn't explain it to me,
Yeah.
and I didn't understand it, but they would say, when you're working on a person, sometimes so you'll feel things release, and people will start crying, and they'll start, or sometimes screaming even, things like this. And, and so that started to become, if nothing else, interesting. And so, but what I found, was that what we do well in Western medicine is this idea of, if we find something physical, we're very good. Like, if you come in and you have a broken bone, we set it, we pin it, works great. If you're having belly pain, you've got appendicitis, we cut out your appendix, works great. If you're having a chest pain and you're having a heart attack, we go in, we can open up the artery, it works great, right? So if we can identify something physical, and these are mostly in acute situations,
Yeah.
Western medicine tends to work very well. What I found, though, is, as you were suggesting and we were talked about, the majority of the people who come in with new complaints, we don't find anything physical, and that's where I think we kick a brick. That's where I think we're just much less effective with our pharmaceuticals. And so I liked, when I was evaluating these people, I spent more time, and I called it awareness-centered health,
Yeah.
and that was, yes, someone come in, let's just say chest pain, palpitations. That's, as a cardiologist, obviously I saw a lot of that. You're gonna get, even with seeing me, you're gonna get the standard evaluation with an ECG, maybe an ultrasound, like a cardiogram, maybe some kind of stress test, maybe a catheterization, whatever, to make sure you don't have heart disease, because that's, you
Mhm.
wanna make sure, not heart attack or unstable angina or coronary disease, whatever. But again, 85% of the time, we didn't find that. So that's when I looked at what I like to call the non-physical dimensions of health. So we're great with the physical, but the non-physical dimension of health, things like mental health and emotional health, behavioral health, cultural health, social health, spiritual health, these are all aspects of a person, of health, that we tend to ignore in Western medicine. We just concentrate all on the physical. But what really happens, as you were suggesting, these emotional sort of issues ultimately can manifest physically.
Mhm.
And it's not woo-woo, mumbo-jumbo, airy-fairy bullshit. I mean, it's like, we understand the neuroscience of it, right? So
Right.
if you're sitting there, right, and let's just say you're sitting there in your office and you heard an explosion outside your window, right? You'd get startled
Mhm.
instant. And when you got startled, your blood pressure would go up, your heart rate would go up, your muscles would tense, your pupils would dilate. All of these physical changes would happen when your sympathetic part of your autonomic nervous system got stimulated in its fight or flight response, because there was an explosion outside, and your nervous system, before you had any thoughts, of what was that or whatever. Before any of that, your nervous system made a prediction, and
Mm.
that prediction was that's an explosion, and it always defaults to safety.
Yeah.
So, you even might have like ducked or something and,
Mhm.
right? Not knowing what that was. No thought is involved with that, and it happens like instantly,
Right.
millisecond, which blows my mind because there's, parts of your brain like your amygdala and your hypothalamus the fear center, and there's neurotransmitters that get secreted, and then that causes a cascade of hormones and epinephrine that gets secreted that then causes the blood vessels to constrict. Heart rate goes up, blood pressure goes up, all this stuff happens almost instantly, right? And so that I is what happened there was really just a thought. That thought came from experience,
Mhm.
right? Your experience and experience not you may not have just experienced it, but you may have learned it.
Mhm.
Explosions tend to be bad things,
Right.
right? And so when that happens, you have this stimulation of the sympathetic nervous system, right? But then, so in other words, it was just a thought that caused a change in your physiology, not just a change, but like a drastic change in your
Yeah.
physiology, right?
Yeah.
Because because if you were just sitting there and you heard it, your blood pressure would be up and your heart rate would be up. Well, now if you went out and you thought, you know, y- you had heard in the news that there was something going on, and you said, now maybe, there's something happening that's bad in my neighborhood here or
Mhm.
whatever, right? Now you have a second thought, which is more fear. So
Mhm.
now your heart rate's gonna go even higher, your blood pressure is gonna go even higher. So these are but then you go outside and you look and you find out that someone lit a firecracker right outside your window, right? Now you say, "Oh," so now you get another piece of evidence for
Mhm.
your nervous system that says, "Oh, that's okay. That's not dangerous." So now everything starts to calm down. But nothing really happened yet. These were
Right.
all sort of thought-related things. So
Mhm.
we don't talk much about, that's a simple thought. But what if you have that same thought of anxiety producing thing about your work? Maybe your boss is a jerk or something and is always
Yeah.
giving you a hard time, right? And you're anxious about work, or maybe something that's as a home situation that you're anxious about or fearful about. And so if it happens as an explosion outside your window, you find out everything is okay, it's gone.
Right.
But when it's in your daily life and it's going on every day and you're always thinking about it and it's always in the back of your mind, right? Then how does that ultimately translate to the physical?
Yeah.
And this is what became sort of fascinating to me. And so it was a patient comes in, you find out, is anything physical going on? You have belly pain? Do you have appendicitis? Do you have acute cholecystitis? Do you have Crohn's disease? Whatever. You want to make sure of all that. The majority of the time, you don't have any of that, right? And so then you start to look at these non-physical dimensions of health. And if it's the belly, maybe the medicine's really not all that effective. You might try nutritional programs. Absolutely. There's no
Yep.
reason why you wouldn't do that. But in addition to that, start to look at sort of where are these you probably notice I haven't used the word stress.
Yeah.
I try to avoid that word, because it's very ambiguous, it means different things to different people.
Mhm.
But regardless, let's just say you start to look at where are these stressors in your life, then figure out how to deal with those.
Right. So my big question, the $60,000 question here, Julius, is do you think in medicine we're any farther than you were in 1986 when you bring this to your colleagues of does a thought create this much change in a body? Like the placebo created that much positive change. Does this stress response create that much negative change in a patient?
I think we understood this better 100 years ago than we understand it today, or at
Oh,
least believed in it more. Right?
okay.
So I think in those situations, the country doctor was more effective than, today's primary care physician because he was part of the community,
Mhm.
knew you, he may have birthed you, he knew your family, he knew
Yep.
maybe your father was alcoholic, he knew maybe your husband can be drinks and maybe he's abusive also, and you come in with headaches, he
Yep.
knows. You don't have to tell him.
Yeah.
He knows all that, and so then maybe he might give you something for the pain, but he might also start to work on some of these kind of emotional issues. In the non-traditional, form, the more indigenous forms of medicine, like ancient Chinese medicine, Ayurveda, even Native American medicine, even though they may have used an herb or something, you know, to treat symptoms, in
Yeah.
addition to that, there was always this, emotional component, this emotional therapy
Yeah.
that they implemented as well. Short answer to your question, I think, is I think, inherently know this as physicians, but
Mhm.
we because we don't have a treatment for it or an easy treatment for it, we don't have a pill for it, we tend to, I'll just say, ignore it because that's
Yeah.
really what happened. But if you think about it, if you think of migraine headaches, right?
Mhm.
The medicines for migraine headaches today are much better than they were. There are medicines for prevention, there's medicine to
Yeah.
treat the pain. And again, I don't have an issue with the medicine, right?
Right.
But but, like, there's always this emotional component to it, and from my standpoint, yes, go ahead and treat the headache with your pills or whatever you're gonna do, but in addition to that, every migraine patient, I think, should see a therapist. Like,
Mhm.
why wouldn't you?
Right.
Right.
Well,
Or you can do it yourself. You don't have to
yeah.
send to a therapist.
Yeah, it's interesting because I often explain to patients that anything chronic, and I'm not saying more than 3 months is the, defined definition of chronic, but anything that's long-term and chronic is multifactorial.
Yes,
So
yes.
you would have to bring in the emotions and components. And, and you mentioned the country doctor, and I have a, story well, this is when I was very young. I was an infant and my brother got sick and I got sick and our family doctor came to our home and my mom was so upset that the doctor came to our home because the doctor came to our home and was the house clean, and the story goes that good old Doctor Sebensma, who was kind of a fixture in Grand Rapids, said, "Mrs. Mark, I've touched your doorknobs. They're not sticky. Everything's gonna be okay." You know, and
Like,
so
alright.
and that relieved my mom just saying it that way, and she just realized how, uptight she was our that made a whole big difference for her that she realized she was a good mom after all, really, but
Yes. We had the same thing. We had a physician in Detroit that used to come to the house as well back in those days. Amazing. So they
yeah.
were all everyone was always worried about bothering the doctor to come
Mhm.
and
Yeah.
was the house clean enough?
Yeah, yeah, so that was really, really kind of fun. So, okay, so we've got this, and there's a lot of this type of information out there as influencers, right? Let's just throw I'm gonna throw some of the influencers under the bus. They'll shall remain nameless, but there's a lot of people, professing to know lots of things. And when you look at I always put this slide up when I talk about anxiety, that it's literally full of squares because I Googled it, how to fix anxiety. And there's like 60 blocks or 60 squares on this slide, and so you can change vagal tone 60 different ways. Well, I say, well, it's because the vagus nerve goes everywhere. You have a lot of entry points, right? Which would make sense. And because the majority of the fibers, the afferent fibers go up, that there's also, the super highway that way. So explain to us what something like humming. Sometimes I hear it called wooing. Sometimes I hear it, 4, 7, 8, I think is the breathing, one of the breathings. Explain to us why that makes a difference and that the tool itself doesn't matter, but it matters that you find a tool,
Yeah.
right?
Yes. And I think we actually understand those tools subconsciously. Like I think we're born knowing this. So, right, because what happens after you heard that explosion outside your window, and then
Mhm.
you find out you get all upset, and then you find out it was a firecracker, it was no big deal. What's the first thing that you do? Ah,
Exactly.
that's the first, and you do it without even thinking about it. That sigh actually is vagal stimulating the vagus nerve, right?
Okay.
So we understand these things, and I think um, we may not call it humming, but the other thing, if you think about having a bad headache, right? And you're really sick, nausea and vomit, whatever, and you're laying down in a dark room and you've got the things closed and you're moaning, right? You may be sitting there going, "Oh, oh," you're right? And that why are you moaning, right? But that's actually stimulating the vagus nerve.
Interesting. Okay, I never thought of that one.
Yeah, so I think we do this just instinctively. I think we're born knowing how to breathe. Most
Yeah.
of us forget it. If you watch an infant breathing, they
Yeah.
have diaphragmatic breathing, right? You see their belly going up and down. In our society, it doesn't look when your belly pooches out, so we keep it in.
Yeah.
And so we forget how to breathe. We breathe with the chest and we don't breathe with the diaphragm, right? And so, but I think we also inherently instinctively know how to stimulate the vagus nerve. But then, there are other mindfulness techniques. Meditation is great.
Mhm.
So I think there's as many, and maybe 60s even, maybe it's some 60,000 ways to do it. I don't know.
Yeah. There was a lot.
Yeah. It really is a lot, and I think, I think the important thing there is that there's all these natural ways to do it, and you don't need a $50,000 implanted medical device to stimulate the vagus.
Right. So what you're saying is that using these tools, so using these tools create vagal tone. Could we look at vagal toning the same way as I'm going to use this abdominal toning?
Yeah.
The more you approach it, different angles, different ways, that you're going to use it much easier because you've got it kind of already primed a bit.
Yeah, I think that's exactly right. So I think when you need to practice these things,
Mhm.
not because you don't know it, because like I said, you instinctively know, but we forgot it.
Mhm.
Right. So you need to remember it and you need to practice it so that then it becomes natural. Right.
Yeah.
So that when you're going into, a committee meeting or a board meeting,
Yeah.
and you always get worked up and maybe you get nauseous and maybe your heart races, right? Then before you even go into the meeting, or even once you're sitting in the meeting, because you can do these things, you probably don't want to hum like in a board meeting.
Right, exactly.
But you can still take literally 15 seconds, right? And do a mindfulness sort of practice where you just ground yourself, right? Where you feel your feet on the ground, the back of your thighs against the chair, right? And you ground yourself there, and that stimulates the vagus nerve as well. And you can do that in the middle of the meeting.
Yeah.
And so, but if you practice it enough, then you can do it naturally, as opposed to coming out of the meeting with this bad headache and going, "Oh, man, I didn't think about, you know, something to stimulate my vagus nerve or something like that."
Yeah. I think that's really good, and we've got some nice tools instead of I have seen external vagal stimulators that some of my folks who have POTS, which is the positional orthostatic tachycardia syndrome, which often we've seen with some of the long haul COVID folks and different things. I've seen that create some very nice stability over time. But what I found is when they use these stimulators, the other thing I also found is they said, well, you know what? I also picked up a breathing technique and I also am starting to do meditation now. I'm like, oh, so there was more vagal toning that was going on in addition to just using an external stimulator that they could take on and off. And I did and I'm so glad that you brought that up about, widening your choices there because I saw people gravitate right towards more tone in for the vagus nerve, and they probably were just having a good time is what I would think, and it felt really good. And then they were coming out of that stress response and like, "Oh, this is actually more comfortable."
Yeah, what's interesting thing about that, I've seen there are many devices out there now, as you suggested, like external devices, and I don't have a problem with them. I mean, if you wanna go ahead and buy them and use them, and you find them helpful, but it's interesting to me how, as a society, we are always looking for things outside of ourselves.
The
For
external locus of control.
That's exactly right, right? And that's what pharmaceuticals are, right? It's like diabetes, I think, is like the poster child for this, right? Because think about as you know, type 2 diabetes is absolutely epidemic in our society today,
Mhm.
right? And though you do have to be genetically predisposed to develop type 2 diabetes,
Mhm.
that's a given. we know today that you can modify the expression of those genes based on your lifestyle,
Mhm.
right? And so as much as anything, type 2 diabetes is really a lifestyle issue more than it is a genetic issue, right? And
Mhm.
I think if you as you know, most type 2 diabetics, are very sedentary and they're overweight and they
Mhm.
eat poorly, but it's not in right? And so I have no issue with the medications because especially the medications today are much more effective at treating insulin resistance than the old sulfonylureas, right, that were
Mhm.
pretty
Those are
crazy
challenging. Yeah.
those days, right? But, nonetheless, it's still we people don't want to make the lifestyle changes or even look at the lifestyle changes. They're like, "Doc, can't you just give me a pill?"
Mhm.
Right? But the pills aren't gonna reverse your diabetes, and they're not gonna cure your diabetes, whereas, weight loss, increasing your activity so I tend not to use the words exercise or diet because exercise is associated with, going to the gym, getting on a treadmill, lifting weight. Diet is associated with deprivation, restriction, weight loss. So I like to talk about activity, live an active lifestyle, and I like to talk about nutrition and understanding your nutrition, and then also understanding the why. Like, why do you eat the way you do? Because it's like smoking, right? People always say, "Do you tell your patient not to smoke?" I said, "Actually, everyone knows not to smoke." Like,
Right.
don't really see why but I'm more interested in why do you smoke? Why do you overeat? What's your pattern of eating, right? And get people to understand this. But becoming more active, and understanding your nutrition and your nutritional program, those are people have to do. The doctor can't do for you. So I always say at Gratefully Well, this platform that I started, the very first thing that I have in there is a patient has to be willing to accept some degree of accountability for
Yes.
health and healthcare. Not 100%. I'm not saying to ignore the doctor. The doctor has to be involved as well. And if you have diabetes, the medicine's very important. If you have migraine headaches, the medicines may help. Irritable bowel, maybe not so much. But regardless, but in addition to those treatments,
Right.
you need to also participate and you need to do your part as well if you want to sort of get healthy.
Yeah, I think that that's really good. And I think we're gonna be I think people, I think we're I'm optimistic that we're at a crossroads in our culture, and I don't even know how we're gonna get there because that's not my job to know how we're gonna get there. But I'm sensing a change, and I'm actually pushing my patients towards that. I do genomics, and when we review the genomics around food, nutrigenomics, and then it's spelled out on the paper what to do, they look to me and they say, "I'd like a meal plan, please." And I say, "There it is right there. I would like you to research this out yourself and get involved."
Yeah.
I mean, certainly if a person were to Google Mediterranean style eating with polyunsaturated fats and extra fiber, you could find some beautiful recipes that would not involve me writing them out for you because really I would politely, as I do politely say, that's not my job. And so, but I think that getting that level of engagement and also one of the things too about not finding the physical symptoms and rather the physical signs, because that's what we find objectively. The symptoms are what they're experiencing, the signs are what we're finding, is so many people are afraid that there's something wrong with them.
Yes.
And so we're able to come in underneath and say, you're okay, you're not broke. We're going to find the ways to work with you so you can stay strong, get healthy, follow your journey that way. And, just reassuring a lot of times that there's nothing wrong with you and that's okay. Can really be helpful. Like, I guess maybe that's akin to the sticky doorknob, right?
Yeah. So a couple of things there. I think I agree with you first. I think that you sort of have to approach this in two ways. So first, it's interesting because someone comes in with some symptom and you tell them there's nothing on the test, whether it's, let's say just take headaches as an example. You
Yeah.
say, your neurological exam is normal or your MRI is normal.
Right.
Don't have a brain tumor causing your headaches. You don't have anything physical causing your headache. And sometimes you almost see people like dejected, like they're kind of like,
Yeah.
"Oh, no, you didn't find anything. Oh, that's terrible." And I'm like, "No, wait a minute. You don't understand.
That's
They
a
don't
good
want
thing.
us to find
No,
something
no, this is not one you want to pass it over.
outside
Right.
that
Yeah.
it wouldn't be good, right?"
Right, right,
And
right.
so then there's kinda like this, "Oh, that is good. But now what?" Right? Because now you haven't found anything. Now, as you sort of suggest, like in our society, once you get sick, right, then that's sort of it gives you, especially if you find something physical, it sort of gives you the excuse, right? See, it's not my fault. I
Mhm.
had appendicitis. That's what sort of caused my belly pain. So, so that's sort of I think part of it. But then the second part is really I'm not as you suggested, we're not saying this is all in your head. Yes, if you had a headache, it is in your head.
Right,
If you
right,
had belly pain,
right.
it's not in your head. It's a true symptom, right? And I mean, irritable bowel can be really debilitating for some people, right? With sometimes they get nausea, sometimes they get terrible diarrhea where they're afraid to go out, and things like that, right? And so it can be very,
Mhm.
debilitating. And so, not to say we don't believe your symptom, not to say it's all in your head, it's in your gut.
Right.
But what's causing this? And you get them to start understanding what is going on. And I think, changing their nutritional program is important, very important in irritable bowel. But in addition to that, getting them to start to understand, hey, what's the pattern of this? When do you get your symptoms, right?
Yes.
Start get them to understand that there's this emotional component before you get to what you can do about it. First you have
Yes.
to.
Yeah, and that's, was the one of the last changes because I could get a lot of folks who had really serious chronic illnesses 85, 90% well. And then that last turning of the corner was going into the emotions, trauma stored in the body, and really approaching that from the nervous system wants that released and treated. And so, well, this has been, just absolutely fascinating. I'm glad that you're pursuing the same question you pursued as a young physician, and to me, that means that you're a very curious, intelligent, and dedicated healer, to be
Well,
quite
flattery will get you everywhere with me, Mary.
Yeah, yeah, but no, I'm serious on this one because
Thank you, brother.
yeah, I mean, I really feel that's the case, and so what we'll do is you've got speak a little bit about your programs and your website so we can get people directed there who want to engage more with you.
So, I'm not seeing patients directly anymore at the
Mm,
at the office, and so I was trying to decide, what I do with my career at this point, and I had this experience with seeing patients one-on-one in the office, face to face, right?
right.
And what I did, obviously, I had the physical stuff that I did as cardiologist, right? But then I had this, whatever you wanna call it, this non-physical kinda stuff, and, um, and I found that the process was somewhat intuitive, right?
Mhm.
It wasn't all that structured. And so I decided that I want to have a bigger reach. And so I started a platform
Mhm.
called Gratefully Well. So
Mhm.
we didn't talk much about gratitude, but gratitude became a a tool, a big tool, a significant tool in the program. So I found a couple of decades ago, there's a whole body of literature on gratitude, the physical and mental health benefits of gratitude. And I found this fascinating. I'm like, why aren't we prescribing gratitude more often? So the platform is I call it a digital educational holistic health platform called Gratefully Well. There's a website called gratefullyWell.com. You can go there. There's a free 3-day mini course on the physiology of thought.
Okay.
That's there. I have a newsletter on Substack.com that's also called Gratefully Well.
Nice.
People can go there. This newsletter's free, and I write about this stuff there as well. And then I started putting on workshops. So at first I was going to have courses that people could sort of just buy or whatever, but I found that I needed to be more involved, just reading it in a book or a course. I do have a book on Amazon also that talks about the physical and mental health benefits of gratitude. But I thought I needed to be more involved. So instead of the courses, I'm doing workshops. And I've done a couple of these pilot workshops because it's been a bit of a challenge. How do I translate what I did one on one to a group setting?
Yes, that is a huge challenge.
Yeah.
Yes.
And I never had any training like as a group facilitator or anything like that. So I'm learning that as I sort of go. But I've been impressed with the limited amount that we've done. people are participating more than I thought they were. I think the lockdown really helped with that, as far as, people are comfortable with the virtual setting.
Mhm.
And they're sharing in the group, which is I think important because it becomes almost like a support group. These
Mhm.
are small groups of like, 10 to 20 people. Uh, and,
Nice.
and there's a discussion, and some people bring stuff up. And so it's been a learning experience for me and it's been fun. And I think people have so far the feedback has been very positive.
Yeah. I've heard it said that, the vast majority of people need coaching and support versus a physician or a specialist.
Yeah, it's
And so
very
and
interesting.
yeah, and so, moving into that realm of, really a health coach, and that's not a disparaging thing, and you're cheering people on in a different way and not having to be exactly tied to the insurances, tied to the outcomes. That gives you a lot more freedom of movement, and I think the outcomes, would be pretty amazing, to be honest.
It's interesting you bring that up. No one's brought that up before, but it's true. Like, when I looked at what I did in practice,
Mhm.
like, even take a heart failure patient, right? So I used to have 30-minute appointments for my follow-up patients, and I would spend the first, I don't know, let's say 5 or even maybe 10 minutes on the physical stuff. "Oh, look, your blood pressure's too high, your cholesterol's," whatever. We would adjust the medicines. That would take 5 minutes. 'Cause the pharmaceutical stuff is easy. Then the rest of the time was spent on this, whatever you wanna call it, let's just call it emotional sort of stuff. And and so when I really looked at my practice, it was more, I'm not trained as a counselor, it was more coaching, than it was anything else, but it was sort of done under the guise of the cardiology, right? So the
Right.
cardiology is certainly, part of it. Now I'm flying a little bit sort of, naked somewhat because I don't have the cardiology stuff that I'm doing with people, and, so it's been interesting, for me as well.
Well, I think you're speaking from a huge platform of, experience, and that anybody who would take your courses or would get a wealth of knowledge and support from you. So, as one healer to the other, I recognize, really the work you're doing, and so I really wanna thank you for your time today, Julius, and thank you for the work that you're doing on behalf of many people because I think it's really important, and I think your approach is spot on. It's not too dissimilar from mine, so I have a bias there. I'll expose that bias, but I also see the how patients respond or now people in the coaching aspect respond and just kind of getting rid of some of that medicalese has been so wonderful to see people transform, and that's really what you're after, seeing their lives transform. So it's a wonderful place to be, and I'm glad you're in that space. I'm glad we're in that together, even though this is the first time that we've talked, and I just really appreciate, the work that you bring. So it's
Well,
wonderful.
I appreciate the kind words, and I certainly appreciate the opportunity, the invitation.
Yeah. Well, thank you again, so folks, we're gonna have the resources on our, podcast, page for this, so you'll be able to follow up with Dr. Torelli and see what his work is and get involved. And thank you again for being here. And we will see you guys next time on the Dr. Mary Lauder podcast show. Thanks for being here. That's a wrap for this episode of the Dr. Mary Lauder podcast show. I hope you've heard something today that made you think, laugh, or say, well, now that was a plot twist I didn't expect. Just remember, your health journey is more than lab results and supplements. It's spirit, soul, and story, and sometimes a gadget or two you probably should have returned. If you enjoyed the show, please rate and review us wherever you listen to your podcasts. And please share our podcast with someone you love. If you didn't like the show, well, maybe don't tell anybody then. And if you want more soulful medicine, curious conversations, and tools that actually help, visit me anytime at drmarylauder.com. Until next time, stay kind and stay curious. Music today is provided by Mr. Dave Evans. He composed, played, and engineered this song specifically for our podcast, and it's called Soul Strings, an acoustic reflection of the healing path. Thanks, Dave. It's great music.